So today we're going to be talking about the neuro-ophthalmology of pregnancy. And in the pregnant state, most of the problems that we see in neuro-ophthalmology are about volume and fluid shifts that occur during the pregnancy and also the hypercoagulable state of pregnancy. So those are the three main mechanisms by which we're going to see changes in terms of vision loss or diplopia and other neuro-ophthalmic problems in pregnancy. So the first thing is pregnancy affects the entire visual pathway. And what that means is it can cause dry eye, it can affect the tear film, it can affect the cornea and change the shape of the cornea, it can affect the lens and change their refraction. So we really don't want to give pregnant ladies glasses or contact lenses while they're pregnant because it's likely to change. Once you get beyond the anterior portion of the eye, it can affect the middle part and the back part of the eye from the same mechanisms that we just discussed: blood flow problems, blood volume problems, and the hypercoagulable state. And so if it's an afferent problem, then we're really worried about decreased vision in one or both eyes. And that can be from an arterial occlusive event like a branch retinal artery occlusion or a central retinal artery occlusion or a branch retinal vein occlusion or a central retinal vein occlusion. And so we always want to be worried about the hypercoagulable state of pregnancy when patients have clots. In addition, those clots, the thrombosis, can produce pulmonary embolus and deep venous thrombosis. But for us in neuro-ophthalmology, we're going to be concerned about cerebral venous sinus thrombosis. And that is going to present to us as increased intracranial pressure and the symptoms and signs of increased ICP like papilledema. So in every patient who is pregnant who we think might have IAH, you still have to be thinking about cerebral venous sinus thrombosis, and that means MRI plus MRV. And most people would agree that an MRI scan without contrast is probably safe. The gadolinium is category C, which means there's some risk. I would talk to OB/GYN before doing any kind of MR study on this person. So if we are not dealing with an arterial or venous sinus occlusive event, we can still have vision loss from stroke, and that can produce homonymous hemianopsia, or be on the efferent side with diplopia and nystagmus if it's a brainstem ischemic event. And we can have reversible events that are vascular. And the most prominent are posterior reversible encephalopathy syndrome, PRES, which doesn't have to be posterior, doesn't have to be reversible, and doesn't have to have encephalopathy. It's usually characterized for us as cortical blindness or homonymous hemianopsia with a bilateral hyperintensity on the T2 and the flare. And the differentiating feature is, as opposed to cytotoxic edema from stroke, the diffusion-weighted imaging will not show the restricted diffusion. So the DWI will be normal, or it might just show shine through. And we need to correlate that with the ADC. And the other reversible syndrome is the reversible cerebral vascular syndrome, which is vasoconstriction. So when we have reversible cerebrovascular vasoconstriction, that can cause stroke and hemorrhage, including subarachnoid hemorrhage or intraparenchymal hemorrhage in pregnant patients. So those are the reversible forms. Obviously, stroke may or may not be reversible. And so, again, with the DWI, on a stroke, we're going to see restricted diffusion. Both are going to show hyperintense T2 in PRES and stroke, but in stroke, restricted diffusion. And we have to worry about eclampsia and preeclampsia, and that means checking the blood pressure is a super important part of any of these presentations. Making sure it's not eclampsia, preeclampsia spectrum. We always want to consult OB/GYN, and we're going to be checking to see if the patient has proteinuria as well as checking their blood pressure. So hypertensive changes can worsen during pregnancy, and they can present with hypertensive urgency or hypertensive emergency. Likewise, diabetic retinopathy can worsen during pregnancy, both the proliferative and the non-proliferative forms, and that is associated with the comorbidity of hypertension. So these two things together sometimes get worse during pregnancy. And so fluorescein angiography and OCT are useful in patients who are pregnant who have vision loss, in which we're worried about the retina, both looking at macular ischemia, proliferative disease, and hypertensive retinopathy, hypertensive choroidopathy, and hypertensive optic neuropathy. In addition, fluorescein and OCT might show fluid, and that can look like central serous retinopathy. Also, we want to check the blood pressure and look for preeclampsia in those patients. Some of those patients have HELP, which is hemolytic anemia, elevated liver function studies, and low platelets. And so the combination of the central serous retinopathy and PRES should really be making you think about the comorbidities, the overarching pregnancy-related comorbidities of HELP and preeclampsia, eclampsia syndrome. In addition, some tumors grow during pregnancy because of the hormonal effects, and that's pituitary lesions. The most classic is the Sheehan syndrome, where patients have acute bitemporal hemianopsia from pituitary apoplexy. Aneurysms also can grow or rupture during pregnancy related to the blood flow and blood volume, and so patients might have carotid cavernous fistula of the high flow type spontaneously because there's an intracavernous aneurysm that ruptured. You should also be thinking about aneurysm in the normal circumstances like pupil-involved third nerve palsy and the other ways that aneurysms come to us in neuro-ophthalmology. Because the blood flow and the blood pressure go up during pregnancy, the aneurysm might present during pregnancy. And finally, the other hormone-related and hormone-sensitive tumors, meningioma and schwannoma, can grow during pregnancy. A lot of the autoimmune disorders and uveitis and MS attacks seem to go down during pregnancy, but after they deliver, the immune system, which was suppressed during the pregnancy to keep you from attacking your baby, turns back on all of a sudden, and so you might get a recurrent attack of autoimmune disease after delivery. So in summary, the neuro-ophthalmic findings of pregnancy, you really should be thinking about pregnancy-related changes across the entire visual pathway. It can affect the afferent or the efferent system. It's about blood flow, blood volume, and the hypercoagulable state of pregnancy. We want to be making sure in our papilledema patients that we did for cerebral venous sinus thrombosis, think about the reversible syndromes, PRES, and reversible cerebral vasoconstriction. Always measure the blood pressure and ask the OB/GYN about proteinuria because preeclampsia, eclampsia can occur with any of these presentations. And fluorescein angiogram, OCT, and a non-contrast MR are probably safe in pregnancy. And for the fundus, think about central serous and serous detachments in pregnant patients.